So good evening, everybody. We are here from the EIZOC Secretariat for the Ophthalmology Resident Teaching Series 27. I am Dr. Swaraj Bhattacharjee, and Honorary General Secretary of the EIZOC, welcoming all. We had with us the mentor of the program, Dr. Ajit Babu Majhi, the Chief Coordinator, Dr. BNR Subudhi Sir, and our Chairman Scientific Committee, Dr. Sabyasachi Patnaik, and all our panelists, speakers. We had our speaker today, Dr. Akshay Nair from Aditya Jat High Hospital, Mumbai, and our moderator is none other than Dr. Aparna Dwivedi. We had our panelists, Dr. Sharmishta, Dr. Pami Rai, Dr. Manu Saini, and Dr. Sonam Nisar. And we had discussing the PGs from different medical colleges of Eastern Zone and beyond. Now it's my turn to give the podium to our president, to Dr. Pranav Ranjan sir, to welcome the gathering. Over to Pranav Ranjan sir.
You're muted.
Pranav,
You're muted.
you are muted.
Pranabji, you're muted.
Unmute yourself.
A very good evening, everyone, and thank you, Dr. Swaraj Bhattacharya. And I, on behalf of EIZOC, welcome you all to this very common and important topic, which is orbital infection and inflammation. This is the Ophthalmology Resident Training Series number 27, and today our speaker is Dr. Akshay Nair from Mumbai. The webinar will be moderated by Dr. Aparna Dwivedi, and we have a panelists in Dr. Sharmishta Behra, Dr. Pammi Roy, Dr. Manu Sahani, and Dr. Sonam Nisar. And we have residents from different institutions of the East and beyond. I must express my gratitude to Dr. Ajit Babu Majhi, who has been the mentor of the training series, which has been happening every fortnightly, along with Dr. BNR Subudhi, who is the chief coordinator. I also express my my happiness and gratitude to our secretary, Dr. Swaraj Bhattacharya, and Chairman Scientific Committee, Dr. Sabyasachi Patnaik. And above all, I welcome all the audience, the postgraduates who have joined this webinar. This is going to be very informative. And just one information, we are going to have our annual conference in November, that is 29th of November, 30th of November, and 1st of December at Kalimpong, West Bengal. The registration will open shortly, and all of you are invited to attend the annual conference of EIZOC. These words, once again, welcome you all, and over to you, Dr. BNR Subudhi, sir, and Chairman Scientific Committee, Dr. Sabyasachi Patnaik, to speak a few words before Dr. BNR Subudhi takes over. Dr. Sabyasachi Patnaik.
So thank you, sir. Thank you very much. I welcome our President, Pranav Ranjan sir, and Dr. Swaraj Bhattacharya, the Secretary of EIZOC, to this program. EIZOC, as all of you know, or some of you might not be knowing, is an organization of five eastern states and the northeastern states. So the five big states are Odisha, West Bengal, Bihar, Jharkhand, and Assam, and all other northeastern states. As per our academic activities that we conduct annually, we have an annual conference that Dr. Pranav Ranjan has also mentioned just now. We are going to have it at Kalimpong. And also we do one midterm conference in the northeastern states. So last time we had our conference at EIZOC and attended by Dr. Ajit Babu also, and many of us present here. So coming to our this virtual program, we conduct ORTS, the Ophthalmic Resident Teaching Series, and ORP, that is Ophthalmic Research and Publication Initiative. So in this regard, we have now reached around we have conducted so many programs with the mentorship of Dr. Ajit Babu Majhi, who has taken a lot of interest in organizing this program, and really is enjoying interacting with the residents and the postgraduates. He sincerely wants that our postgraduates and our residents should sign at international and international level. So all the postgraduates and residents, those who are attending today, we must endeavor to clarify our doubts, because this is a forum where you can directly interact with the speaker, and we try to make it as a classroom forum, so that any doubt, anything, whatever or however silly may be, don't think that if I will ask this question, people may think otherwise. So this is the only inhibition which prevented us to move forward. So I request all of you to be very open in discussing with our speakers. With this brief introduction, I welcome Professor G.N.R. Subhuti, the coordinator of the program, who is taking all pain in arranging this program, to proceed further. Thank you very much. Thank you.
Sir, can we have a word from our mentor Ajit Babu Manji sir before?
Yeah.
2 words.
2 words is I'm longing to listen to Akshay, who has such a good outlook towards life. So my good friend will speak nicely, and he will make it interactive, so that maximum benefit shall be extracted by the postgraduates.
Yes, sir. Thank you, sir. And Subhuti sir.
Thank you. My screen is visible.
Yes, sir.
Yeah.
Yes, sir.
So I welcome on the occasion of Bahuda Rath Yatra. You know, everybody, today is the Bahuda Rath Yatra. Sri Jagannath returned to his home. So I bring greetings from the Odisha. Am I audible?
Yes, yes.
Yes, sir. You are audible, sir.
Yes. So once again, I welcome you to our program, Apthal Residence Teaching Series, the 27th number. And today's speaker, Dr. Akshay Nair, and topic will be orbital infections and inflammations. So our EIZOC team is with us today. President Pranab Ranjan, Secretary Dr. Swaraj Bhattacharya, and Chairman Secretary Dr. Sabasat Patnaik were always constantly, with this program. And of course, our mentor is always with us. With the mentor, we select very good topics and very good speakers, and to interact the postgraduate students. And it is going on strong day by day, and will continue in future too. So today's speaker is Dr. Akshay Nair, and of course he is well known to us. He is mostly associated with, I know him from the HMS, Help BC programs. So today's speaker will be introduced by our moderator today. I will not speak much about him, but he is very well known to all of us. Dr. Aparna Dwivedi, yes, she is currently works at Dr. Agarwal's Eye Hospital, Bhubaneswar, as the consultant of Orbit Oculoplasty and Aesthetic Services. Welcome, Dr. Aparna.
Thank you, sir.
Today's panelist, Dr. Sarmishta Behra, Professor, Bhimsar Medical College, Bhimsar, Burla, and is always with us in our ORTS and RP programs as a panelist and moderator. Dr. Pami Rai, welcome, Dr. Pami Rai. She is Assistant Professor and HOD at JNN Medical College, Bhagalpur.
Good evening, sir.
Sorry?
Good evening, sir.
Good evening. Oh, you joined. So, Dr. Manu Saini, she is the Assistant Professor, PGM at Chandigarh. And of course, we are waiting Dr. Sonam to join. She is the Associate Consultant, Sankanta Chennai. And today's residents who have participated in this program are more than 10. So they are Dr. Subhasri Saw, Dr. Ankita Misra from the MKS Medical College, Berhampur, Dr. Krishna Priya and Dr. Subhasri Prasad from Silchar Medical College and Hospital, Dr. Smruti Misra and Dr. Lipsa Mahapat from Bhimsar Burla, Dr. Bharat Mittal from HIMS Lucknow, Dr. Sonali Sai, GMS Sundargarh, Dr. Akshay Kumar from AIMS Patna, and Dr. Jai Dakshini from Ruby Hospital, Berhampur. So these are the postgraduate students. They will be interacting at the end of the talk with the panelists, moderators, and the speaker. So welcome you all to this program. So with these few words, I now hand over the mic to Dr. Aparna Dwivedi to moderate and introduce the speaker. So it's
Maybe
over
Sharmishta
to
can speak 2 words about mid-year OSOS.
It's over to Dr. Aparna.
Sharmishta, 2 minutes.
Sorry, yeah.
1 minute के लिए.
Okay, Sharmishta just.
Yes, sir. Respected seniors, dear residents, and dear colleagues. OSOS, Odisha State Ophthalmic Society, is going to conduct its midterm OSOCON at AIMS Bhubaneswar. And I take this opportunity to invite each of you, please come and join us at Bhubaneswar on date 21st July, that is a Sunday. It will be a day-long program, it will be a half-day program. Please come and join us. We would be delighted to have you with us. Thank you so much.
Over to Aparna.
Yeah, that's over.
So we all know Dr. Akshay Nair as a prolific young oculoplasty surgeon. This introduction is basically for the newcomers who are into this field. So please listen out to his talks because it's very interactive with a healthy dose of humor. So Dr. Akshay Nair has been trained at Shankar Netralaya and LBPI. He is currently affiliated to Dr. Agarwal's group of eye hospitals and also at Hiranandani and Shankara Eye Hospitals in Mumbai. He has authored around 145 peer-reviewed index publications and 18 chapter articles and has been listed in the top 2% of the most cited scientists globally for the past 3 years. His chief areas of interest are periocular aesthetics, endoscopic lacrimal surgery, and orbital fungal diseases. Over to you, Dr. Akshay. Without any more delay, let us start your talk.
Thank you so much to EIZOC, EIZOC, Dr. Ajit Babu sir, who's been a teacher and mentor right from my LVPI days, and Dr. Subudhi sir for the kind invitation, and Aparna, of course, as a colleague, now that we work in the same hospital. Thank you for that introduction. So I've divided my talk into two parts. One is orbital infections, which I think is extremely important in our, as for residents who are in the casualty, in the emergency room. Orbital infections can be one of the most commonest things that you see in the casualty in an emergency. So you need to know first if it is an infection, and B, what to do when it is an infection. And that's precisely what I'll be speaking on. Dr. Ajit Babu sir specifically mentioned this is directed at residents. So I'm going to, without taking any delay, I'm going to go straight to the residents. Our first answer, the first resident, I don't know the list.
Subhashri Shahu.
Dr. Subhashri, are you here?
Yes, sir. Good evening, sir.
All right, sir, ma'am.
Yeah.
So can you tell me, this is a patient who's come in. She says for the past 3 days, she's having swelling, pain, and it's really unbearable for her. What do you think it is? What is going to be your next plan of action? Or if you want to ask me any more questions.
Sir, we will check first.
Before you answer, it's perfectly okay to answer wrong, because that's the only way we learn. So
Yes.
don't say I don't know or pass or something. Give me a wrong answer so I can tell you.
The right answer is obviously welcome.
Extraocular movement, sir. Extraocular
You are
movement.
not audible so much, Subhashri.
Hello.
Yeah.
Hello, sir. I am audible.
You are not audible. Ankita, can you answer this?
Yes, sir.
Yeah, you are audible. Yes.
Uh,
Please go ahead.
we can see the preseptal cellulitis we can suspect.
First, describe and then come to a.
There is presence of lead swelling and edema, along with mild ecchymosis. So we need to check first for the extraocular movement. We need to see the conjunctival chemosis there present or not, or there is any visual difficulty.
Any questions you would want to ask?
Extraocular motions.
Insect bite or any other trauma?
Insect bite, okay. She didn't have any insect bite. She only has watering or discharge for the past few weeks and 2 days of pain and swelling.
Yeah, what do you suspect? You can come out, no problem.
Yeah, go ahead. What is your diagnosis? What did you say?
Yeah, she told initially, but
yeah, she said preseptal cellulitis. All right.
Yeah, I described her about the diagnosis because first description is more important.
Correct, I agree. So Yes, you're right. It is preseptal cellulitis. Secondary to
Bacterial.
what about watering and discharge that she's had before? So this is acrocystitis, which is called the preseptal cellulitis. All right. So cellulitis essentially is an infection of the skin and the subcutaneous tissue. So when we say you said preseptal cellulitis, why are we, what can the next resident tell me what is the difference between preseptal and orbital cellulitis, and why are we talking so much about we having, being very particular about the distinction between the two?
Dr. Lipsa.
Sir, preseptal cellulitis is
I think there is a connection problem.
in front of the orbital septum, and sir, preseptal cellulitis.
Your audibility is a little bit difficult.
Breaking. It's breaking.
Yeah, it's breaking. Smriti Mishra is there?
Yeah. So Dr. Lipsa, maybe if you turn off your video, your audio may be audible. Yeah, go ahead.
So preseptal cellulitis is the infection in front of the orbital septum, and orbital cellulitis is the infection if the infection occurs behind the orbital septum. And in orbital cellulitis, there is chance of involvement of optic nerve, and so the extraocular muscle may be extraocular muscle movement may be hampered.
So you're right. So the three things, you see that those three things that I put, that if you can take one thing away from this talk, that should be this. When you are facing with a patient who you're not sure whether it's preseptal cellulitis and you don't know whether it is orbital cellulitis, you want to be sure, check three things. If there is proptosis, which means the inflammation is involving the orbit, it is pushed the globe in front, there is proptosis, this is orbital cellulitis. If the pupil is involved, as Dr. Lipsa said, that means the optic nerve is already involved. So RAPD or visual loss of vision, reduction in vision is another sign that it is orbital cellulitis. And finally, if ocular motility disturbance is there, if diplopia is there, obviously the extraocular muscles are affected. That means it is orbital. You don't need a combination of all three or any two. Any one singly is enough for you to go ahead with the treatment as orbital cellulitis. Now, why is it important to know the difference? Because the most important thing is that they are prognostically completely different. Preseptal cellulitis is unlikely to have major complications. Preseptal cellulitis is most likely due to an external source. It could be a sty that is causing a preseptal cellulitis. It could be an insect bite that's causing a preseptal cellulitis, or a furuncle or a pimple that causes it, or even dacryocystitis. But in orbital cellulitis, it is usually inside out. It is endophthalmitis or panophthalmitis that causes cellulitis. It's sinuses that gets inflamed most commonly that causes orbital cellulitis. And of course, you have now in India, the microbiology trends are almost similar for preseptal than orbital. But can the next trainee tell me what is
Smriti Mishra.
Dr. Smriti Mishra? Can you tell me what is the most important difference in the treatment strategy of the two?
You are muted. Please unmute yourself.
Hello, sir. Am I audible,
Yes.
sir?
Yes.
Yes. Good evening, sir. Sir, the treatment will vary as in preseptal cellulitis, just oral antibiotics, or in case if the infection is very severe, then we may use intravenous antibiotics as well. But in case of orbital cellulitis, we might have to take a more aggressive treatment. I mean, intravenous antibiotics should be the mainstay of the treatment, along with if there is the optic nerve involvement, we may also opt for steroids.
Right. So you've taken already covered my next 5 slides in the 5 sentences, but that's very correct.
Very good.
The most important thing remains that Remember the in preseptal, it is very accessible to the superficial. Infection is superficial. So oral antibiotics would be adequate. Once the infection goes into a closed compartment like the orbit, remember there is a kind of a compartment syndrome developing. The orbit does not have lymphatics. It has a high venous and arterial supply. And for the oral dose of the antibiotics to reach into that tight space is very, very low and ineffective. Therefore, the most important treatment strategy is intravenous antibiotics in orbital cellulitis based on the antibiotic sensitivity as compared to only oral in preseptal cellulitis. So, taking a step behind, periorbital cellulitis is an umbrella term for all infections, all tissues around the eye. It's not per se a diagnosis, it represents the entire continuum of severity from one end of the spectrum to the other, and it can be because of multiple things. So, in periorbital or cellulitis, it is graded or classified into this. And this diagram tells you very nicely how one is preseptal and the thickened red part in front is the orbital, is the tissue in front of the orbital septum. So infection in that area is preseptal. Once it goes into the orbit diffusely, it's orbital cellulitis. Sometimes from the sinuses, directly the infection goes either medially or superiorly, and there is a pus pocket that is seen underneath the periosteum, which is a subperiosteal abscess. Once that ruptures or breaks into the orbit, you have a diffuse orbital abscess. And as it goes posterior, it goes into the cavernous sinus and causes cavernous sinus thrombosis, which is an emergency, life-saving, life-threatening emergency. So my next question is, who classified this periorbital cellulitis into these 5 groups? Who is our next?
Akshay Kumar is there? Akshay Kumar. There is a postgraduate is there, Akshay, not you. Yeah, okay. Ankita Mishra. Ankita Mishra.
Yes, sir.
Yeah, please.
Whose classification system is this? Also a comedy character from a comedy sitcom.
Chandler classification, sir.
Chandler classification, not the Chandler from Friends, but Chandler in 1972, an ENT surgeon, classified this, and it's very useful because it very clearly tells you what you see the MRI and you know exactly which, or the CT scan, and you know which category it falls into. So this is the Chandler system of classification. And why do we stress so much on the difference? Like I said, these are the signs. If you want to take a screenshot, it's the perfect time. Clinical features that differentiate preseptal and orbital cellulitis. Pain with EOM is the most important thing that tells you. Again, like I said, proptosis, vision impairment, or diplopia, ophthalmoplegia will always, either one will be present, but pain on EOM is another hallmark of orbital cellulitis. All right, so it's orbital cellulitis. Our next resident, can you just give me a checklist or run through a laundry list of things that you are going to do in the emergency room next?
Dr. J.
Dr. J. Dakshini.
Yeah, Dakshini.
Yes, sir. Good evening, sir.
Good evening. Tell me, what will be the next set of things that you will do once you see a patient and you have confirmed the diagnosis that yes, this is cellulitis, I need to treat it?
Sir, routine blood investigation, sir.
Okay.
Then, sir, if some fluid or pus is there, then we would like to culture it, so it will help us in deciding what antibiotics and culture sensitivity report would help us, sir.
Okay, but where will you get the pus from?
If there is, sir, not generally.
Okay, there is no, but how do you know that there is pus or not? You mean from the eye, from the conjunctiva?
Not conjunctiva, sir. If some hypopion or something is present secondary to a orbital cellulitis infected.
So that we are going into.
How do you know that the abscess is there or not, or a focus of infection is there, pocket of infection?
So, sir, we would like to go systematically. We would now, once we have diagnosed, the next step of action is how we plan it. How do we investigate further. So we'd send the patient for investigations, routine blood investigations, specific investigations. If you're suspecting specific disease, then B scan we can do, sir. CT scan of the brain to find out any association, the cause of the orbital cellulitis, sir.
So imaging is the most important thing.
Yes,
that
sir.
is to be
Imaging.
done.
Yes, sir.
You're
Orbital
right, all
CT
of it.
scan.
So imaging, and what would you choose, CT or MRI?
CT, sir.
CT. Why do you think you would want to prefer CT?
Yeah.
You're giving the right answer. Don't worry.
I have seen my sir, but I'm not sure why. Sorry.
The most
No,
common cause
what is
for-
the difference CT and MRI? Which tissue gets highlighted in CT? Which tissue gets highlighted in MRI?
So sir is leading you to the answer, huh?
Yes.
Yes, sir.
I'm assisting them.
Yes, yes. You're the lecturer who is going around helping the students in the Viva.
Oh,
Yes,
yeah,
sir.
obviously.
In the final exam.
But I want to help them get into danger, actually.
Sir, CT is for bones and bone tumors and base for that. Since CT for bone.
It is also the imaging choice for paranasal sinuses.
Sinuses, yes, sir. Bone and bone.
So we suspect sinusitis to be the most common source of this in cellulitis. So
Yes,
CT
sir.
would be preferred. If it is
Yes, sir.
atypical signs that you see, then you may think of MRI.
MRI.
Alright. You are correct in saying blood work needs to be done, and always as a rule, blood work first and send the blood culture and then start antibiotics. Don't.
Yes, sir.
That is the most common mistake that we always do. We bombard the patient, start cefazolin, start gentamicin, start metro and vanco, and then after the first dose, they will draw the blood and send for blood culture. Already the damage is done. The first dose of antibiotics is almost always bactericidal. Subsequent doses are only bacteriostatic. So you've already inhibited the growth of the bacteria in your blood culture. I mean, of course, if you've given the right antibiotics. So get the blood culture out before sending for antibiotics. And antibiotics you can start after that. Your route of antibiotics has to be intravenous in orbital cellulitis. Remember, always supportive treatment in the form of anti-inflammatory drugs, local supportive measures like hot fermentation, decongestion, steam inhalation in patients with sinusitis is very helpful. And like I said, the first three things on top, your pupil, your vision and motility, you need to check it 12 hourly to know that the patient is improving. If you can do it 4 hourly, 8 hourly, and you have enough juniors in your unit, even better. But otherwise, you need to do it at least 12 hourly. Now, orbital cellulitis, like I said, can spread usually from preseptal cellulitis surrounding the eyelid and the lacrimal sac into the orbit, or it can come from the paranasal sinuses, or hematogenous spread remotely from somewhere else in the body and coming to the orbit as well. Or it can also be a spillover from intraocular infection, like we said. It is not uncommon to see a pan-off with an orbital cellulitis type of picture because the spillover is easy from there. All right. So our next resident will point out to me what all do they see in this.
Again, Subhashri.
Subhashri, if I tell you one thing, if I see a scan like this in a patient with cellulitis, I am very happy. Why?
Subhashri?
Yes, sir. Yes, sir. Sir, question, sir, again.
So what? Okay,
I want to know the question.
What do you see in these scans?
What are the positive
Sir, there
signs
is
that you are?
proptosis. Sir, there is proptosis in left side eye. And
So,
then.
Okay. So
then
I have a few slides on imaging and I'll explain how to go about. As a rule, always start by saying, what do you see? Is it MRI? Is it?
There is a CT, sir, CT imaging.
Right.
And there is first there is a involvement of paranasal sinuses.
Right. And those star marks are also telling you the sinuses are filled. So
yes, sir. There is.
The question is, why would someone be very happy?
Yes,
because
there is presence of sinusitis.
Correct. So now you know ki, okay, the focus of infection has been
source.
identified.
It's from PNS.
Correct. If I see a cellulitis patient, but I see the sinus is clear, that is when I start worrying, because then I have to hunt where has this come from. It could be an old chest infection in past 2-3 days. Patient could have had loose motion. Patient could have be having one small little boil with pus somewhere in the ankle. Patient could be diabetic. I've had a patient who had typhoid and then presented orbital abscess, and we actually he had just finished a course of Ciplox 5 days ago, and then developed cellulitis with a pus pocket there. We drained this subperiosteal abscess, and to our surprise, that grew Salmonella typhi. He eventually had even end off and need to be eviscerated, and even the eviscerated specimen showed Salmonella typhi. So it was endogenous end off with cellulitis from typhoid. So if I see sinuses filled, I am happy. I know this can be treated, and we know we've identified the focus. All right, our next resident, I need you to tell me the top 3 differentials of bacterial orbital cellulitis.
Dr. Lipsa.
Dr. Lipsa from Windsor, Burla.
Sir, first case is bilateral presentation, so it is maybe case of cavernous sinus thrombosis.
Okay, cavernous sinus thrombosis, I'll put at say number 4 or 5 in the list. But it is one of the differentials, I'll give you that. Something more common. Okay, so can someone else give the answer or try to answer?
Ankita Mishra.
Ankita?
The thyroid of orbital ophthalmopathy, sir.
Thyroid eye disease, very correct. Thyroid eye disease would be your number 1 differential diagnosis for orbital cellulitis.
Yes, sir.
Yeah. Any other differential you can think of? All right. So, orbital inflammatory disease. So one of my commonest things that I always focus on is never call this a pseudo tumor, because orbital inflammatory disease is a true inflammatory disease. That mass that you see is an inflammatory mass. It is a true tumor. It is a mass there. It's just that it's not a malignant tumor, and pseudo tumor is very broad, non-specific term.
Not only that, once you diagnose pseudotumor, it is a diagnosis of exclusion rather than inclusion.
Absolutely. So pseudotumor means idiopathic orbital inflammatory.
Yes. Once you rule out all the other diagnoses, then only pseudotumor can be squared.
And finally, cysticercosis or other helminthic inflammations in our part of the, generally in India, cysticercosis is very common, intraocular, ocular, periocular. So that can also present with chemosis, proptosis, ptosis. So the principles of treatment of orbital cellulitis, and when I say talk orbital cellulitis, it is usually from the paranasal sinuses. So bacterial cellulitis is to start aggressive antibiotic therapy, always give gram-positive coverage and gram-negative coverage along with one anaerobic. Now anaerobic also, usually they prefer medication that can be given intravenous. So always intravenous antibiotic therapy to be started first. Treat the underlying predisposing factor. You will always ask your ENT colleague to also have a look and say what needs to be done additionally. Do you think you want to do a FES at this point or do something? Usually it is not needed. The antibiotics will help in resolving that. Control comorbidities, because if the patients don't respond as expected or they are they don't improve at all, then you must also be dealing with comorbidities like diabetes or immunosuppression that need to be treated. Surgical management.
Akshay, yes. I want to ask one question to you.
Yes.
That you suggested a gram-positive, gram-negative, and an anaerobic. Usually in endophthalmitis, we say you go with a specific antibiotic.
Right.
So either gram-positive or gram-negative, rather than a combination or a cocktail.
Right. So usually we prefer. In that slide that I showed. Yeah. So it can be either Staph aureus, Staph, pneumonia, and other strep are the most common. So if you give a cephalosporins, 90% of the time you are going to be correct. It is almost always going to cover that. Very rarely you will have something like a Klebsiella or something else pop up. So I agree with you. It is good to start with a good broad spectrum gram-positive coverage. And if you feel that there is no, so if it is a treatment naive patient who's come to you with no previous antibiotic, then I agree with sir what sir has said. We start give only gram-positive. But nowadays, unfortunately, patients almost always have taken 1 or 2 rounds or have been, and the saddest part is incomplete dosage or incomplete regimen of the medication. So they start with augmentin, take 1 tablet for 3 days and say, kuch farak nahi hua hai. So those are the cases where we need to not only start again, but also expand the coverage of the medication. So again, like I said, gram positive with gram negative. But yes, treatment naive patients, we can start only with gram positive as well. Surgical management is only in cases where on imaging, you will see that you are not able to see a well-defined focus of or a similar a concise pocket of pus. You see diffuse inflammation and patient is not responding. At that point, you may want to go in and debride. Associated foreign body, if it is not responding to treatment, always think that there could be a foreign body and ask your radiologist to see again. And most commonly, indication for any intervention is localized abscess or a subperiosteal abscess, which may need to be aspirated transcutaneously. So when do you press the alarm button and you see that start worrying is when there is failure to respond to medication for at least 48 hours, or it deteriorates while on maximal medication. That means there is worsening visual function or pupillary changing, or you see that there is development of orbital abscess, which means there is orbital apical involvement or intracranial extension, which means a patient who had only mild motility restriction now has complete ophthalmoplegia with involvement of all cranial nerves. Then you have to worry and say, oh my God, now this is an orbital abscess. So surgical intervention is only for a medial or an inferior or a superior. The superior is less common, medial and inferior, because the ethmoid and the maxillary sinuses are the most common sources for pus to form a subperiosteal abscess. Now, I think in the images we saw that there is the subperiosteal abscess. How does it look like? So here on the left, here it's not very clear, but yeah, that is kind of a medial subperiosteal abscess that you see. Let's see here. Is it there? Yeah, no, it's not in this image. All right. So I'll just go through a couple of interesting cases. These are not your standard cases, but cases of cellulitis that threw us off completely. This is a 17-day-old infant, normal birth history, 5-day history of bilateral eyelid swelling. And this is a child. Fever, treated with IV antibiotics for 3 days somewhere, and then came with no improvement and referred to us. Now you can see that the entire eyelid, you can almost visualize the pus in the fornix by just pressing the eyelid. So there's pus all over. Clearly there is proptosis. So we imaged. There is proptosis, there is chemosis, there is sluggishly reacting pupils. Now here you can clearly see how a subperiosteal abscess looks like. Those pockets of pus pushing the globe outside, arising from the bone. So here we took the patient up, did an ultrasound guided pus aspiration, transcutaneous, put in a needle, aspirated nearly 7 to 8 ml. And at this point, our pediatrician told a very important thing, that let us do a CSF tap as well. Because the only case where you need to do a CSF in orbital cellulitis is bilateral orbital cellulitis. Because the source of infection here is actually the meningitis, and because the lamina fibrosa or the bones is so permeable that the inflammation from the meninges easily seeps down into the nose and the orbit. And true enough, they identified the bacteria in the CSF, and we treated with antibiotics and steroids also. And finally, you can see over the course of the next 1 week, the child improved. The child improved so much as to have absolutely no neurological deficit with normal responses to visual stimuli. The child is 5 years old now and is absolutely healthy and responding, has completely recovered. So orbital cellulitis can also be a life-threatening emergency. The takeaway from this case is bilateral orbital cellulitis, always suspect meningitis as well. So you must have seen steroids in orbital cellulitis and wondered why steroids in an infection. So steroids in infection is something that we've now recently started. It is controversial because you wonder, why do you want to give an immunosuppressive medication in this? The thing why we give it, like I mentioned, is that the orbit is a tight compartment. If there is inflammation, there is perivascular exudation, the space gets compressed even more. So by giving, reducing the level of the circulating cytokines, you are reducing the mucosal edema, you are allowing better drainage of the sinusitis from the in the sinuses and causing early resolution. And this was the rationale in sinusitis that we use steroids. And extrapolating this, there have been many papers, this one from AIMS in 2013, where they use oral steroids as an adjunct to intravenous antibiotic therapy, starting on the day of treatment. There have been other papers that have said that, again, this study was the first one that they recommended IV steroids on admission. Subsequently, of course, there have been papers that have given some guidelines and said, start steroids after 48 hours when you have documented improvement. So you know that your antibiotic regimen is taking care, and then you give steroids to further improve the rate of resolution. So I'll go to a second study, second case. This is an 11-year-old boy, just to show how steroids can be really effective. He had a history of a sty on the upper lid for 3 days, gradually increasing, but he thought it would go on his own. The parents were doing just some hot fermentation, started increasing with pain, fever, soon he had proptosis and elevation restriction. There was a lid abscess that was drained, and the IV antibiotics were continued. After 3 days, there was no resolution and was referred. So at this point, we could see that there is a drainage point. Again, motility was restricted, and there was proptosis. So we did a CT scan, and there was a large preseptal abscess with fat stranding. So we drained it transcutaneously. And again, in that drainage, we saw a small wooden piece. So the foreign body was the reason why he was not improving even 3 days after antibiotics treatments. And 48 hours later, there was no proptosis, the motility was full, and he was discharged on oral NSAIDs, while we also started oral steroids. And at day 14, you can see he looks as good as he was from the day like he never had cellulitis. So steroids definitely help in improving, but only after you made sure that there is no foreign body and there is documented improvement in the patient, so that your antibiotic cover is working. So bacterial. Yes,
how
sir.
do you suspect foreign body here? And if you are suspecting, what investigation do you do to rule out?
So usually one of the things that we wonder why there is patient will give a vague history of a foreign body, of some trauma many days ago, many weeks ago, and will give episodes of repeated subclinical infection. Sometimes the eyelid or the cheek keeps happening some swelling, and then it goes back again.
Yes.
That is one. Second is, again, patient has been treated with IV antibiotics for 3 days with no response and has come. Imaging helps immensely in identifying and localizing the foreign body. Nowadays, of course, the most common foreign body to cause this kind of inflammation is always a vegetative foreign body, which is wooden, which is seen well even on MRI as well as on CT. Because if you're suspecting a metallic foreign body, this MRI is contraindicated. So those would be the pointers where you would think that, okay, there could be a foreign body, a past history of trauma, varying episodes of subclinical inflammation, and non-response to at least 48 to 72 hours of therapy. So that's what I said, high degree of suspicion when response to poor therapy.
Do you try UBM in this case? Because we do UBM for first. See, if it is superficial.
Yeah, I think a USG or USG will
UBM. USG, UBM, both orbital USG plus or minus UBM.
Absolutely. That will be a
And
great idea.
a second aspect is wooden foreign body. Mostly vegetative foreign bodies are associated with fungal, and it is not responding to antibiotics.
Yeah.
How do you take care of that? And if you start steroids, it may worsen further.
Absolutely. So so again, if you see any sort of foreign body, we have to go in and remove it. And then once we remove it, we can then culture it. And always, like you said, we'll be able to pick up the foreign body and contaminants will be there. So you have to do a thorough lavage. So
Yes.
intraoperatively, one thing for that is to, we take dilute betadine and keep flushing it at least 5-6 times so that 50-60 ml of betadine has gone all around the wound, even around the that tract that the foreign body may have created. So steroids have a role, but only after documented improvement. Don't empirically, in those papers in the West, they may have said steroids on admission. Our Indian patients are very different. Please do not start steroids on admission, only after documented improvement, and treat comorbidities as well. So I'll come to my third case, and now I want a PG to describe this. This just describe it.
Lipsa is there? Lipsa or Jay? Lipsa, you can start. No problem.
Sir,
Just tell me, what do you see?
so there is a swelling below the eyelid.
Above the eyelid, that's right. Okay, so now see, the patient is telling you pain, complaint of pain and double vision. Vision is okay, and there is a 5-day history. Now, based on what we've heard till now, what is your next step?
Sir, oral, sir, incision and drainage. And sir, as there is a patient is complaining regarding pain, so first we put for oral antibiotics for 5 days.
Okay, so one of the things that we said is the 3 things to look for that differentiates preseptal and orbital cellulitis. Can you remind us again?
Vision, pupil, and motility.
So here we see patient is saying he has double vision, which means that motility is affected somewhere, right?
Okay, sir. Yes, sir.
So would you still consider oral therapy, or you think you may want to change your line?
Sir, I intravenous antibiotics.
All right. So I heard one more word from another PG.
Yeah.
Someone said.
Someone, yeah. Who is
that? So we'll go for CT scan to localize the. Okay.
Right. Yes.
Okay. So you're right. Imaging would be the next step, but here the patient has no sign. Now look at the localization of the infection. Yes. This doesn't look like it is a sinusitis related infection because it's not near the ethmoidal sinus, the maxillary sinus. It's anterior and below. I mean, agreed. Frontal sinus is there, but frontal sinus is rarely a source of the abscess that comes in from there. So in this case, we did this an MRI. Can you now say what do you think appears to be here? Or what do you see? Just tell us what you see or describe. Yeah, there is a
hyperdense lesion surrounded by it's look like some cyst.
Right. You're correct.
Very good.
Very nice. The only thing dense is for CT. Intense is for MRI. Isodense, hypodense, hyperdense is CT scan. Hypointense, isointense, and hyperintense is for MRI. So in MRI, now you're right. You're seeing a localized cystic area with hyperintense shadow or hyperintense signal all around it. So it is a cyst. So what cyst causes inflammation in the orbit with pain? The answer is already there.
Cysticercosis.
That is correct. So this is a cysticercosis, and in the image above, which is the coronal slice, that hyperintense dot within the cyst is the scolex.
Yeah, there is a scolex as well as calcium.
There is a scolex, and that speck is the calcification. So, orbital cysticercosis, what would be the treatment? Our next PG can tell me.
Smriti Mishra.
the treatment should be antihelminthic medications like you can go for albendazole.
So albendazole treatment of cysticercosis is a question in the Bible. You should know the dosage at the back of your hand.
Dosage.
So 15 milligram per kg in 2 divided. And always give oral steroids as well in these patients. All right.
So one thing I would like to add is that because there was a double vision in this case, you thought of involvement of a muscle, and that's why you asked for an MRI and not a CT scan.
Excellent.
So that so the symptoms will guide you towards whether you want to take an MRI or a CT scan in your particular case.
No,
And
if you see the Aparna here, if you need to examine the ocular motility in this case before you suspect that kind of a muscular involvement.
So the patient was already having a double vision. So
Yeah.
And the steroid that is given over here is to control the spillover once the cyst ruptures or for the surrounding tissue inflammation.
Yes, yes.
That's correct. I think very valid point. The patient's symptoms guided us in the imaging, and also if you do not have access to an MRI, the simplest thing that you can do is use an ultrasound as well.
Ultrasound, yes. We have seen so many orbital cysticercosis involving the muscle, mainly.
So
orbital USG is better.
So in a week of treatment, it had almost completely improved, and at 1 month it had completely resolved. So painful diplopia is the hallmark of on isolated just one muscle with no spillover inflammation. Painful inflammation that begins with painful diplopia is should guide you towards cysticercosis. And especially if on imaging you will see a cyst but no sinusitis, and B scan can help. Remember, cysticercosis can go and sit in any part of the body or any part of the eye as well. Inside the eye, anterior segment, posterior segment, intraretinal, in the orbit, in the extraocular muscles, in the lacrimal gland, in the skin. So here you can see patient presenting with ptosis, presenting with the lacrimal gland mass, with orbital cellulitis, with proptosis, and with diplopia, with extraocular muscle involvement. So varying presentations of cysticercosis we see. Again, like I said, ptosis, proptosis, and periocular mass. So all of these cases, you need to do the same thing. The treatment remains the same. You start with antihelminthic, give oral steroids cover, and then non-steroidal anti-inflammatory medication.
While assessing the extraocular muscles on USG, how do they differentiate? Any postgraduates can answer this. A parasitic infection from orbital, thyroid ophthalmopathy. Dr. Jay.
Yes, sir. Sir, can you repeat the questions? Yes.
So I've enlarged the image for you also.
Yes. In ultrasound B scan of the orbit,
yes, sir.
How do you differentiate involvement of the extraocular muscles by either parasitic infection or thyroid ophthalmopathy?
Sir, in thyroid ophthalmopathy, there will be tendon sparing, sir. But that won't be visible on B scans. Tendon sparing will be there, sir, which is characteristic in case of thyroid eye disease, sir. And the belly will be swollen, but tendon will be not swollen. But it won't be the case in parasitic disease, sir. And in parasitic here, we can see that scolex is there, sir, which will help us in deciding or coming to a diagnosis, sir.
Yeah, not only that, you need to do a B scan with A scan combined.
A scan. Yes, sir.
So that the reflectivity can be analyzed.
Yes, sir.
All right. So while we are, because the entire spectrum of inflammation and infections also covers mucormycosis, something that we saw
very
exceedingly high numbers, and we, of course, now we still do see
during the
them,
COVID,
not
yes.
as many. Yeah. So presentation of mucormycosis can present in many ways. Again, it would be typically a typical patient presents with ptosis, ophthalmoplegia, and vision loss, which is all signs of cellulitis. But you will see an absolutely quiet eye. There is no conjunctival chemosis. There is no congestion. There is barely any proptosis. Of course, as the disease worsens, you will see all of those signs. But in the early phase, this is how it will be. So ptosis, frozen globe, vision loss, and proptosis without active signs of nasty inflammation or something of that sort. And as the disease worsens, is when we see its true self, where it can, cause these nasty eschars, orbital abscesses, orbital infarcts with globe melt, and complete, like you can see that partially auto-eviscerated globe as well. So in these cases, we have different ways to treat them, and I'll go over them briefly. We can always, if it is a localized involvement, we debride it. Exenteration is not your sole treatment. A lot of us earlier used to over-exenterate these eyes. We no longer do that. Exenteration is only in the end stage. And now we can also give retrobulbar amphotericin B. So why do we do exenteration? Because if there is too much necrotic material, we have to remove it. If it is involving the right at the apex along with other orbital involvement, we have to prevent it from going further into the brain. And that is why we need to make sure that we have to exenterate it. This used to be the earlier thought, but now we are moving towards a more image-guided decision making. But before any sort of intervention in fungal orbital cellulitis, it could be aspergillosis, it could be mucormycosis. Remember, 99% of a patient with mucormycosis is immunosuppressed unless otherwise proved. Less than 10% of patients with mucormycosis or any other fungal disease are immunocompetent. It is uncommon to see them, not impossible, but uncommon. So always get a multi-speciality board on board, to a specialist on board to do an endoscopic assessment, image the patient, start systemic amphotericin B once you know it is fungal, and then make sure that you control the diabetic control or the other form of immunosuppression without tackling the seat of infection, which is the sinuses. See, these fungal infections comes from the sinus into the orbit. Rarely do they start only in the orbit. So without treating the sinus, without doing endoscopic treatment at the same time, only doing ophthalmic treatment is not going to help.
Akshay,
yes,
you said at the beginning, it's a very silent presentation.
Yes.
How do you suspect?
So the thing is that in earlier non-COVID related mucormycosis or aspergillosis,
Yeah,
these patients will have these symptoms for the past 10 days, 15 days, 20 days, and they would come to you. Very insidious, slow progression. For bacterial cellulitis, it would have rapidly gone.
Rampant.
So these non-COVID associated fungal infections were typically very indolent, relatively slow progressive. It is only COVID that has changed this, and thankfully now, now over the past, at least this year, I've seen only 2 or 3 cases of COVID-related mucormycosis. Even the mucormycosis now that we see non-COVID related are thankfully the same kind of presentation we used to see earlier. So the fungus basically goes into these small and medium-sized vessels and occludes them by creating like an embolus or like a thrombus or causing inflammation within it. So all the blood supply distal to that occlusion is compromised. So there is necrosis and tissue damage there. So even if we give a lot of antifungals, the medication does not actually reach there.
Yeah.
So therefore, we have to either remove all that necrotic material through debridement or take the antifungal and go and put it there. So it's either debridement or exenteration or antifungal injections that we give it directly there. And how do we know which part to debride? By doing an MRI contrast. So earlier we used to say, if there is vision loss, ptosis, and ophthalmoplegia, we have to exenterate. these are no longer indications for exenteration. We do an MRI, and that will help us in telling where the fungal infection is versus where it is now. So what we look for in radiology is LOCE, which is loss of contrast enhancement. Wherever there is contrast, we are seeing, which means the contrast injected in the IV line is reaching the blood vessel, showing up as contrast in the scan. But areas where we see black with no contrast uptake, those are areas that are necrosed, that are devitalized, and they are not taking up contrast, which means they have to be removed, debrided or not. And depending on the amount of contrast loss in the orbit, we can tell whether we can debride and the orbit will survive, or we have to go in an exent treatment. So therefore, the radiologist is always an important part. Now, why a CT scan alone is inadequate? Here we can see sinuses are full. This is, immunocompromised patient with diabetes. We suspect fungal disease. But is that inflammation, can we remove those? Do we need to exenterate or not? How severe is the inflammation? We will know only if we do MRI with contrast enhancement. Now in this, you see on the right-sided eye,
yes.
You can see the and compare the contrast uptake on both sides. The left-sided orbit, the extraocular muscles are so well defined. They are smaller in size and they are clearly taking up hyper-intense contrast. On the right side, on the other hand, the muscles are thickened because of edema and ischemia.
Can you enlarge the image a little bit so that right-sided one? Yeah.
So here, compare the size of this inferior rectus versus this inferior.
Full screen. Make it full screen so that we can see. No. Okay. Yeah.
Yeah. So compare the size of the inferior rectus alone. So here, this is this inferior rectus, and this is this inferior rectus. It is enlarged, and the intensity of the contrast is also less. So this is a case where the contrast uptake is less. You know that there is some contrast uptake, but not completely lost. You can still treat with some amphotericin B, and this will help.
Means retrobulbar injection.
Yeah.
Ampho B.
So in this case, amphotericin.
Retroorbital.
Yeah. So in this case, amphotericin B.
Retroorbital.
Yeah, intraorbital. So I'm just going to clear all these. Okay. Check. All right, we got this done.
Yes.
And now compare this side. So on the left, the image, you can now see what loss of contrast enhancement looks like. There is absolutely no uptake on any of the muscles on the image on the right in the right orbit. And on the left, there is an interesting observation. The left-sided orbit of the image on the left, look at the medial rectus. You can see the medial rectus, but the contrast uptake is only in one small corner of the medial rectus. So that is the sign of a dying muscle. The muscle partially has some blood supply, but the disease is still going aggressively. So in this patient, we actually exenterate the bilateral case, but one side had better disease.
Massive. So not only that, you need to save the minimal involved.
So, and here you see inferiorly in the exentrated specimen on the right-hand side, I've flipped it over. In the center, you see the optic nerve, but below that is all white tissue, which is necrosis. Superiorly, you can see the blood. You can see the vascular extraocular muscles and the fleshy fat. Below, all is white,
avascular.
Again, this is, compare the medial rectus on the left versus the medial rectus on the right. Loss of contrast enhancement. This orbit also has a guitar pluck sign. It has become an inverted heart shape, so has to be exentrated. So again, this is slightly advanced, so I'll not go into the details of what patients do we need to exenterate, what need to be given retrobulbar amphotericin B. Exenteration also comes with its own set of complications, but of course, exenterated patients can be rehabilitated very well with an exentration prosthesis as well. So exentration is offered only when there is no other option, and debridement, when debridement also will not help. But there is an option called TRAMB, which is transcutaneous retrobulbar amphotericin B, which we started using because we saw some cases that were treated, and then we started using them in a lot of other cases as well. Again, this is a patient in who had one-sided, he's already been operated and debrided endoscopically, developed orbital disease later on. Right eye is no PL due to diabetes. Left eye is 624 and has ptosis. So on imaging, you can see that he's already debrided. We did a CT, and then of course we did an MRI as well. The MRI here now shows that right eye has less disease. Both sides are operated sinuses, but you can see that contrast uptake is still happening. So in this case, the disease is, the orbit is still salvageable, and he underwent retrobulbar amphotericin B. First, we give little local anesthesia, and then we inject the amphotericin B. He improved, and thankfully we could improve we could save him without having to undergo.
What is the gauge of the needle here you are using?
So here, yeah. So in this case, we are using so we can either use a 24 needle or a 25 needle.
Yeah.
So whichever is available, we can use. And only
it's a longer.
It's a long needle. It's a long
needle. Yeah. Otherwise, it will become a peribulbar.
Peribulbar. 1 cc syringe, because you can give the dosage is 3.5 milligram per 1 cc. So we finished fungal orbital diseases, and now we come to briefly go over orbital inflammation. So like I said, idiopathic orbital IOID, which is called idiopathic orbital inflammatory disease, or only OID also, orbital inflammatory disease, earlier caused pseudotumor, where we see a patient with inflammation and we used to randomly treat with steroids, not knowing what is happening. It is an open-ended diagnosis where the definite cause for inflammation is not known. Inflammation is a tissue response, so inflammation cannot be a diagnosis. Response to steroids is not a diagnostic criteria, because a lot of conditions can respond to steroids, and many conditions can present with inflammation. So a systemic, and because there are so many systemic conditions that can be associated with this, we have to investigate these patients, because, and therefore, like sir said even before starting, sir, were you doing some orbit cases also earlier?
Obviously, RP center days.
No wonder, because the first thing that he said was never call it pseudotumor, because pseudotumor is when you've never found a cause, and that's exactly the line from my presentation. Find a cause before calling it NSOID or idiopathic disease or non-specific orbital disease or pseudotumor. Only after you've ruled out everything can you call it that. So how does orbital inflammation present? It presents in multiple ways. These are classical presentations that I'm showing. Remember, they can always have spillover, little bit of one and the other. So the first is dacryoadenitis, where the inflammation involves only the lacrimal gland. So again, you will see in these patients, however, the classical difference is that the pain component in dacryoadenitis is almost not there. The patient will have painless swelling, and that will show up. So dacryoadenitis was also thought to be earlier viral related. So you can also, people say that post-herpetic you can get this. So I'll come to the specifications of each of that later. The next is myositis, where muscles are specifically involved along with preseptal inflammation. So painful motility will be there, but again, sinuses are clear, and the other classical signs of bacterial infection like pain, fever, leukocytosis, systemic symptoms, none of that will be there. And finally, in extremely advanced diffuse orbital inflammation, you can have all the orbital tissues involved. And again, there is a lot of chemosis. So in these kind of cases, you may suspect thyroid eye disease as well. So again, we'll come to each of these. Dacryoadenitis can usually be bilateral or unilateral, mostly without pain. It's painless. Sometimes can be painful. The classical S-shaped deformity, because the medial eyelid opens up fully, laterally because of that mass and swelling, it droops down. Patient will come in walking happily, no systemic complaints, but keep telling you, ये एक दो बार पहले भी हुआ है पर अपने आप से ठीक हो गया. So this needs to be kept in mind, that, and you will see an enlarged lacrimal gland on imaging, and also you can palpate it. The next is myositis. This is usually unilateral. It causes pain and diplopia along with chemosis and congestion. So you can see the symptoms are exactly like it can be in orbital cellulitis. Yes, which is why orbital cellulitis is one of your differential diagnoses. But you will see that the sinuses are clear, the bony landmarks are normal, and the horizontal recti are more involved in these cases. And here what differentiates is that you will see enlargement of a muscle. You can see that the lateral rectus here is really inflamed, thickened, with spillover inflammation anteriorly. So now you know there is no abscess, there is no kind of a pus pocket. And this is, again, this is involving the tendon. A lot of times we see only thyroid eye disease images and we know what is tendon sparing. This is what tendon involving inflammation looks like. So this is what rules out thyroid eye disease. And rarely do we also see diffuse orbital inflammation, which is associated with perineuritis as well. You can see the amount of retrobulbar inflammation here. In these cases, again, an MRI is preferred, and you will see vision reduction. So again, thyroid eye disease, bacterial cellulitis, and carotid cavernous fistula, all would be your differentials. Again, imaging would help you in narrowing your diagnosis. So how do you then go about treating these cases? So before treating, you would always want to do a thorough workup, a detailed history to see if there is any other autoimmune condition the patient has. Commonly, previous attacks of uveitis, rheumatoid arthritis, or psoriasis, or any kind of other autoimmune condition may be there. Your laundry list of blood tests, unfortunately, is relatively longer. You may want to do, you should do at least a basic ANA, RA, and ANCA. Serum ACE and CT chest are secondary investigations which you can do later on. Remember, again, unfortunately, the treatment here is steroids. So rule out immunosuppressions, HIV, HBsAg, and tuberculosis before starting treatment. How do you treat? Now, treatment depends on the severity of the disease. So if the patient has mild disease, you can, like you say, everybody is allowed one episode of acute anterior uveitis. So here, if it is mild disease, you may be tempted to, you can actually treat with only anti-inflammatory, like you would do for something like blepharochalasis. But if you see there is severe diplopia, severe pain and proptosis, then you have to do your lab workup, image the patient, and start on oral corticosteroids. Once you do your blood work and wait for the reports, you can start oral corticosteroids and then consider tapering it off. But if it doesn't respond to steroids, is when you may want to do an incisional biopsy or even hike up to other kind of immune suppression medication. So this is just a very brief algorithm of how you want to treat. Again, I understand this is a little advanced for residents, but it's important to know how you treat a typical NSOID. We start with corticosteroids. The moment you see poor response to corticosteroids, you should have a low threshold for a biopsy. Nothing like a biopsy of the lacrimal gland, of the diffuse mass that you see in the orbit, or even a bit of the extraocular muscle, so that you can identify pathologically which is the granulomatous or the vasculitic inflammation that the patient has, and do a tailored workup. And with your rheumatologist, you can treat this condition. There is something known as an IgG4 disease. It is basically an immunoglobulin variant, a type of immunoglobulin called IgG4, which also causes in orbital inflammation like picture. The most important thing here is that when you do a biopsy, you should also get a serum IgG4 level done. These patients have a higher chance of systemic lymphoma. So if you have a patient with this kind of spectrum of complaints, keep that in mind. I see that we are almost close, so I will not go into the details of imaging. I thought I'll just go over a few slides on how to understand what imaging to be done, because we were talking about orbital inflammations. I'll very briefly skim through this. So when you see your first CT film, when you hold it up, this image on the top, that's called a scout view. that shows the slices that have been taken and the gap between them. So when we talk of slices, there are 3 slices. A sagittal, which goes right like this and divides your head into 2 halves. So when you see from the side, that is a sagittal or a parasagittal. Front to back is axial, and down to up is front to back is coronal, and down to up is axial. So if it is a slice like this, that's an axial slice. If it is a slice like this, it's a coronal slice. And if it cuts midway, it is sagittal. So slices are the gaps between the two. So 2 mm slice is that an image will be kept at 2 mm gap between each other. So when you see a coronal slice, it is from front to back. You can see that now. You can see the on the left, you see the globe. Then you don't see the globe because the image is going behind. You can identify the recta and the nerve. And then you can see that the orbit is narrowing as it goes to the apex. This is a coronal slice. In the coronal slice, you will be identifying the globe. And in an axial slice, you will see the ethmoidal sinuses, the nerve, and the recti muscles. And most important, this is a central axial slice. You can see the lens shadows. So whenever the point of all of this is whenever you see a scan image, don't directly say cellulitis. This is a CT scan of a patient.
Yes.
Say whether it is axial, coronal, parasagittal. You are letting the examiner know all that you know. You are letting the examiner know that, see, I know the basics, even though you may not know the answer.
Yes.
And then just describe what you see. The examiner will be happy. He doesn't know the
He will give you 60 to 70 marks for that.
Exactly.
Even if the diagnosis is wrong.
And this is the sagittal slice from the side. So start that way. And I'll tell you how do you describe. First thing is you check if you're holding the film ulta or sida by seeing the print. There only it will be written CT with contrast. So you know half the things are correct. You know, just reading with your eyes open will tell you, give you half the information. Again, on the side, you can see R is written. So that also tells you that is right hand side on this corner over here. On the right hand side near the cheekbone, you can see R. So that is R, this is left. All images have this. Don't worry. It is not some great, hidden secret. Whether contrast is not there, again, that is there on the scan. Just keep your eyes open. If you see a hyper intense speck on a CT, hyper dense speck, or the blood vessels shining, it is with contrast. The image itself will have the information on it. Laterality, like I said, R is written, L is written. Look for that. So it will help you in identifying. In the same CT scan, you will see some cuts where you will see the globe and the muscles well. That is a soft tissue window. Some cuts where you will see the bone well. That is the bony window. So you can again tell this is a soft cut, soft tissue window, coronal slice. You will sound very impressive and informed. Other landmarks that you look for are the lacrimal gland fossa, where the lacrimal gland sits. This is the orbital floor that you can identify and look for. And then all the 4 muscles are connected by an intermuscular septum. Anything within that is intraconal, anything outside that is extraconal. And why does the space within those muscles appear black? Because all of that is occupied by fat, and fat is radiolucent. Fat will not show a shadow on CT scans. So if you see a mass like this, you can nicely say it is intraconal, it is extraconal, it is axial, or it is abaxial, that is just off the axis. So the tumor image on the top right is completely intraconal, whereas the image below is intraconal as well as extraconal. So again, intraconal versus extraconal, and here you can also see the optic nerve tumor is extending intracranially. Then look for surrounding bone and describe the bone if you see any changes in the bone. Here you can see the bone is showing a gentle scalloping. So there is a slight bony, like a scalloping change happening. Whereas here there is a very abrupt angulation. So this is bony erosion, and that is gentle scalloping. Erosion usually indicates a rapid malignant process. Scalloping or gentle shaping indicates that it is a chronic process. Look for the blood vessels that enhance. Contrast will appear as white, dense white in a CT scan. So a superior ophthalmic vein which is enlarged with a picture like this, you know it is a CCF. It will also be marked like that. So dilated SOV again, on the right, you can see how the normal SOV looks like for comparison. So whenever you ask for a CT scan, you remember, you never say, I will order a CT scan. My teachers, Dr. Santosh and Dr. Milind, always used to say, you request a CT scan. So use that word in your exam also. And what do you convey to the radiologist? The areas to be imaged, the slice thickness. In the orbit, you should always request for 2 mm cuts in a CT scan, or axial as well as coronal slices. Whether you want contrast or not, you can also explain and pick up the phone and tell the radiologist, I think I suspect this. So do what you can to be able to help me with that diagnosis. And remember, the absence of a pathology on imaging doesn't rule out a disease in the patient. Because at the end of the day, we are treating the patient, we are not treating the CT scan. So, so to summarize, I will summarize with a couple of questions to the next resident. Who can tell me what is the most common cause of unilateral proptosis in adults? Who's the next resident?
Next resident, anyone? Ankita?
Ankita.
Yeah.
Cellulitis. Thyroiditis.
Cellulitis or thyroiditis is okay.
Thyroid.
Okay, so we'll keep one of those two options in hand. Cellulitis and thyroid disease. Can someone tell me what is the most common cause of bilateral proptosis in adults?
Jade.
Thyroid.
Also thyroid.
Thyroid.
Thyroid
So,
eye disease.
okay, so
Thyroid
Jay
eye
has
disease.
said thyroid eye disease as the bilateral, most common cause of bilateral. Sorry, I thought my screen sharing stopped.
Again, share it. Yeah, right.
Yeah. So thyroid eye disease, we know, is most common cause of bilateral proptosis in adults. What is the most? So now, coming back to the first question, what is the most common cause of unilateral proptosis in adults? Ankita.
Cellulitis.
Cellulitis. So at least someone gave their wicket to my googling. Unilateral proptosis in adults, the most common cause is still thyroid eye disease. It is not cellulitis. Cellulitis is the answer to the third question. The most common cause of proptosis in children is orbital cellulitis. So now, hopefully, with what we've discussed today, you will be able to diagnose cellulitis, because in cellulitis, the diagnosis is as crucial as the treatment, because the treatment basically depends on the diagnosis of cellulitis. Atypical cellulitis, which doesn't respond to treatment or worsens on treatment, needs to be treated with a high degree of suspicion. Pull out the scan, have a look again, request a second opinion, look for something unusual and treat it accordingly. Thank you for your time. And
no, it will go to Aparna now. Aparna
Yes.
was silent all throughout. Aparna,
It was so good, I was listening.
I did your job, please. Aap karo abhi.
Sir, I think the topic has been very well discussed all along the seminar. I really don't think if the children have any kind of queries, then please you can go ahead and ask.
They are not children, madam. They are grown-up adults.
Students are children only.
Students are not children. They are grown-up. You need to. Yeah. You continue. You Aparna, you muted yourself, please. Right.
Okay. Yeah. Dr. Ankit, she is coming up first all the time. She's been bombarded with questions. Smruti has not answered a single question. Are you there, Smruti?
Yeah, Sonali has also not answered anything. Sonali.
Smruti Mishra is there.
Yes, sir. I'm here, sir.
You're silent.
Yes, sir. I was listening.
All the questions, you have to answer.
Smruti, so can you quickly tell me how do you differentiate orbital from preceptal and this? 3 points. Hello?
She must not be there. Smriti Mishra?
All
Yes,
of
she's
for
there.
dinner.
Smriti is there. No, her volume is very low. So ask questions to others.
Okay. Dr.
Hello?
Pranav, are you there?
Pranav is also not there. Rishabh is there. Rishabh is silent actually all the time. Rishabh?
Dr.
Yes, sir.
Rishabh,
Yeah.
Yes, ma'am.
Go ahead. She
do
asked
you
some
have any
questions.
questions, any doubts? Would you like to answer some questions?
I'll answer the question, ma'am.
Oh, good. So, about orbital inflammations, sir had pointed out 3 cases. Can you please tell me the first one, which involved the inflammation of the lacrimal gland? What is that one key clinical feature that you should be looking out to?
Inflammation of the lacrimal gland.
Yeah, dacroadenitis.
Dacroadenitis, madam, it will be painless. Usually present as a painless swelling over the.
Okay. And a very important clinical sign that helps in your diagnosis. It almost clinches your diagnosis. Very good.
S-shaped eyelid.
Very good. S-shaped. And when you elevate, you can see the enlarged congested lacrimal gland. Hello?
Oh, yeah.
So,
Yes,
Rishabh,
yes,
any test that you would want to do in the clinic to see if the lacrimal gland is okay or not? I forgot to mention this in my slide presentation.
Thermos test.
Shermer's test. So Shermer's test is mostly, you would see that you'd get a low value of Shermer's in these patients.
Okay, sir.
Anyone else who has any questions or doubts? Dr. Smriti has joined.
Yeah. They are there. Smriti is there. Lipsa is there. Ankita is there.
Okay.
Yeah, I want to say, I have a question for Dr. Akshay. Yeah,
Sharmisha, please.
Yeah, Dr. Akshay, do you find the tuberculosis as a common cause of dacryoadenitis?
Sometimes, yes, we've seen tuberculosis. So that's why, one of the things that raises suspicion, like I said, because you don't want to treat with steroids. And sometimes these tubercular lesions initially will respond to steroid, but again, they keep recurring. So it's a good idea to do so unfortunately, the only way that I've ended up diagnosing tubercular dacryoadenitis is when after the first round of steroids, they've not resolved completely and they persisted, and then doing a tissue biopsy for it. So yes, we see them, but relatively uncommon, not as common as intraocular TB or other forms.
Dr. Akshay, one more thing I wanted to ask. When you were deciding a case for exenteration during that COVID phase, so does the radiologist give you a percentage that how much amount of tissues have already died? Like, is it 50% or something, which helps you in deciding whether I should go in for debridement or?
Right. So basically what we've, I'll just quickly share my screen. So
can I just say one point? I was in the mucormycosis committee working. So that was when they said only when the orbital apex is affected, you should go think of exenteration.
So isolated apex, I would be a little wary. So this was our based on radiology, clinical examination, and management. So if there is contrast enhancement still present, then our plan would always be retrobulbar amphotericin B. If there is contrast enhancement absent, but extracorneal loss of contrast enhancement over a surgically accessible area is present, then we will do debridement. Loss of contrast enhancement over the apex, like Madam said, orbital exenteration. So again, with imaging examples. So this is a case. So these are cases where absolute loss of distortion of the orbital architecture is there. So here we can't even make out the rectile muscle. So this is exenteration. This is a patient with enhancement at the apex and loss of contrast enhancement of the muscles. So this would be a patient whom we will exenterate. So isolated apical involvement with loss of contrast in the muscles, like Madam said, would be a case for exenteration. Our radiologist didn't give any exact percentage, so we ourselves figured out. So I can obviously share this article. It's fairly comprehensive about how to image and which places to choose for amphotericin B.
ये इसमें अपना ग्रुप में रख दो ना.
Yeah, I'll post it on the group, sir.
Yeah, that will be better.
Any other panelist who has any doubts or wants some discussion?
Just want to add one thing. During the treatment, just for the resident, during the treatment of the cysticercosis, just rule out neurocysticercosis before initiation of albendazole and the steroids. That is very important. Otherwise, it will lead or induce scissors. So just rule out neurocysticercosis before going to the treatment.
That is one thing, and second, hydrated cyst also should be ruled out in orbit. It is much more common than any other location in the ophthalmology.
Second part is regarding the treatment of orbital cellulitis. Of course, it is an emergency situation. It should be treated like a systemic disease because it is generally associated with the constitutional symptoms. So proptosis, chemosis will take some time to get resolved. In the meanwhile, constitutional symptoms resolve. Fever subsided, appetite increases, and there occurs the normalization of the pulse rate, heart rate. That indirectly tells us that patient is responding to the antibiotic. We are on the right track. Otherwise, we have to think something else. It's not responding. Just keep it.
Extremely valid point. Thanks, Dr. Mani.
Yeah.
Hi, Akshay. Dr. Pammi here.
Hi, Dr. Pammi.
Hi. I think Akshay has covered a very good topic and thoroughly. I don't think PG will have any doubts, at least for the diagnosis of any inflammation. One thing I will like to just emphasize for the PGs that before starting the antibiotic, take a blood for the culture and sensitivity so that we cannot lose the eye if the antibiotic is not responding. Okay,
yeah, he
and
has
I
highlighted
think,
that.
That's why I only
highlighted, yes.
I just only want to recall that points because in the PG
100%.
they started antibiotic first and whether they start any antibiotic before taking the blood. And thank you, Akshay. Nice seeing you and hearing you on this platform.
Good to see you.
Thanks, Akshay. Thanks, the panelists and all the moderator. Thanks.
Okay, I think we can call it. We can close the seminar.
Yeah. I think it's time to close.
All right.
So, thank you once again, Dr. Akshanad, joining with us and giving me the widespread picture of orbital inflammation and infections. And thank you, Dr. Pranabji, being with us, and all the panelists, all the students interacting with the moderator and the speaker. Thank you, everybody. Good night.
Good night.
Thank you, sir.
Thank you, sir.
Very nice, Akshay. I learned a lot from you.
Yeah, it's a really good learning. Rahulji, you can close down now.
Yeah. You don't want to thank Enroad?
Sir, he wants to stay for another 1 hour, sir.
No. Only 2 minutes. No, thanking is 2 minutes.
All right, sir. Good night.
Good night.
Okay, sir.
Good night, everybody.
Sir, good night, sir. Subodhi, sir, good night.